If you can see in this table, you can see this color mapping of the area in the placenta. We have green, we have blue color, is that correct? And we have red, right? So the red means that the blood in this particular part area is moving towards the ultrasound probe itself, while the blue ones meaning that the flow of the blood is moving away from the flow. It's not an artery and vein. It doesn't work like this. We have, so this is the red, meaning the arterial, the supply of the flow. This is the direction. This is the first information we get from the moving fluid. The blood is moving towards the probe, and it takes a red color. And when the blood is moving away from the probe, it takes a blue color. It's not an artery and vein. So now this is the direction, right? So where's the velocity? The velocity is the grade of the color itself, the tone of the color. The more dark the color is, the more slow is it. And the more bright it is, the more rapid it is. If you take a look at this gradient, for example, see, this is cm per second. We have dark colors in the middle. This is 0. It means it doesn't move. And we have darker color at the bottom, or the inner end, means that this one, for example, if it takes this color, means moving slow but towards the probe. This one moving away from the probe, but it is still slow. Then we have this bright yellow, meaning very fast, like 75 cm per second, moving away towards the probe. And this one, cyan blue, or the baby blue one, moving away from the probe, but is, very rapid. So when we have like a high turbulence flow, like just in case in placenta previa, placenta accreta, or cancer, or vesicular mole, would you expect which gradient of color? The one on those inner side or the bright colors? Tell me. Yes, the brighter end of the gradient. And we see multiple directions because the blood is highly turbulent. So turbulence means moving towards and back and forth. So the mix between this cyan blue and this bright yellow, we call it a liaising effect. So this is what's meant, if you're not familiar with this term, in the TOG articles, it's mentioned clearly, this is a liaising effect. Take a look at this, for example. See this? Cyan blue, and here, this bright yellow. This is a liaising effect, meaning this high turbulence flow is working there. See, we use the color double in order to visualize the vascularity of the uteroplacental blood flow. See, this is the utrovesical hypervascularity. Striking amount of color Doppler signal, see D capital. This is, as I might have told you, this is after a scientist's name. Signal seen between the myometrium and the posterior wall of the bladder. This is the bladder. This is the posterior wall of the bladder, right? And this is the placenta. And this is the utrovesical high blood flow, right? This sign probably indicates numerous closely packed tortuous vessels in the region, demonstrating multidirectional and a liaising artifact. So we have multidirectional blood vessels moving back and forth towards the probe and away from the probe with high velocity at the brighter end of the color gradient, cyan blue away from the probe and the bright yellow towards the probe, right? This is reflecting deep uterine circulation, radial artery from abnormal proximity of extravillous. We can expect that trophoblast is just right there, next to these blood vessels. This is why there's neovascularization in this part. Did you get me? Good? Okay. My laser pointer. Okay, now seen? Good. We have two types of vascularity. The utrovesical vascularity, so between the uterus and the bladder wall. This is one. And the another one, the subplacental hypervascularity. Well, clinically, it's almost impossible to distinguish between both of them, especially when you're examining the lower part of the placenta. So we have a striking amount of colored Doppler signals seen in the placental bed. This sign probably indicates, again, same. If you look at these 2 points of the table, they almost copy and paste. Same thing. So in the end, we have highly tortuous, multi-directional, high-velocity blood supply between the uterus and the placenta, the myometrium and the placenta, and the myometrium and the bladder. Uteroplacental, subplacental hypervascularity, and uterovesical hypervascularity. Okay, subplacental hypervascularity. This is between the placenta and the myometrium, and uterovesical hypervascularity, indicating this deep penetration of the AVT in this part and new vascularization. This is another example of it. See this aliasing effect? Let me zoom. Yes, just right there. See? Towards the brighter end of the color gradient, the bright yellow and cyan blue, right? Okay, bridging vessels. By the way, these uterovesical and subplacental hypervascularity, the unreliable marker for pulse. Why they are unreliable? Just try and do it yourself. Give me any patient with normally sighted placenta and put me the colored Doppler on this particular part, and you will see subplacental hypervascularity and uterovesical hypervascularity in normally situated non-pus placenta. So just an additive sign. If you just see it by itself, it doesn't mean that you have pus. But if you see it with other markers like interrupted bladder wall, like bridging vessels, like other markers, then this increases the likelihood of having pus. But by itself, no, it's unreliable. It's high false positive, gives you high false positive. So what's actually sensitive in the Doppler? These bridging vessels. These bridging vessels, these are the guys who gave us the equal sign for interrupted bladder wall. Okay, vessels appearing it's very difficult. Yeah, I'm really sorry that you feel this way, seriously. Pulsed wave is a method, color Doppler and pulsed wave. Pulsed wave is a method of visualizing the data from the moving vessels in terms of wave. You get the systole and diastole. Systole in a particular point. Like if I put the pulsed wave modality at this point, for example, this one, okay, here I ask the ultrasound machine to get me the pulsed wave data. At this particular point, if you can see my laser pointer, I should see something like this. Because it's moving away from the probe. This is the velocity and direction. This is like, for example, -3 cm per second, meaning that in this particular point, the fluid is moving at a speed of 3 cm per second away from the probe. While if I put the pulsed wave Doppler here at this point, okay, I should see something like this. Systole, diastole, systole, diastole, systole, diastole. Okay, this is the speed and this is the direction. Moving towards the probe, but at a speed, for example, 5 cm per second. Color mapping gives you an idea, like a mapping of the vessels all around this box inside. Again, direction and velocity. Is this clear? Good. Pulsed wave Doppler is important in obstetrics in small for age, like a uterine artery and umbilical artery pulsatility index, resistive index, and middle cerebral artery. All these indices, we get this calculation from using the pulsed wave Doppler. It's basically, Nidhi, this is the supposed to be the equal sign, but because the equal sign is the artifact due to the bridging vessels. Vessels appearing to extend from the placenta across the myometrium and beyond the cirrhosis into the bladder or other organs, often running perpendicular to the myometrium. Okay, again, these are artifacts arising from new vascularity within the peritoneum seen in 2D cross sections. These will give us the equal sign, again, interrupted bladder wall. So basically, interrupted bladder wall are just bridging vessels. So if you put a Doppler on it, we see those bridging vessels. Let me get back to this nice picture. Yeah, that one. See? This is the equal sign. This is interrupted bladder wall. In fact, these are vessels, but we can see them in black here because these are fluids, and fluids in 2D ultrasound are seen as black, this part. If we put a colored Doppler here, we see this. Yes, see? See the aliasing effect? See the aliasing effect, cyan blue? Right? I hope it's clear now. We've seen this. Okay. Then, yeah, placenta lacunae feeding vessel. Placenta lacunae feeding vessel. This vessel, for example, this one, as I've told you, in the placenta lacunae, there is a single feeding artery coming right away from the lacunar, from the arcuate artery or radial artery, shortcutting the normal structure, coming right away from the radial artery all the way to the lacunae itself. And this high turbulence flow, like this one, see, there is a single feeding artery going through this. You see cyan blue, high turbulence, flowing from radial and arcuate arteries just right away, right through the lacunae, right? Can you see this is the placenta, this is the myometrium posteriorly, so this is where the arcuate artery should be seen, this is the bladder, okay? Single feeding vessel. And finally, we have the intracervical lakes. These intracervical lakes, well, they are nightmares. Why? If I see this as a clinician, if I see these intracervical lakes during or before surgery, before surgery, the ultrasound report, this right away will result in hysterectomy. There would nothing could be done other than hysterectomy for this patient. It's not mentioned in this TOG article, but this is just my observation based on my surgical experience, that if I see this intracervical lakes, this most probably will end in hysterectomy. Tortuous hypervascular anechoic spaces within the cervix, excessive cervical dilatation and cervical dilated vessels resulting from development part of defective placenta in a scar defect. Okay? So the scar should be around here, and these lakes are, this is the transvaginal ultrasound, these lakes are inside the cervix. If I see this, this means there's some like tortuous blood vessels inside this substance of the cervix. You're expecting severe bleeding coming out from this part during the surgery. This corresponds to 3C. See, 3C. This is the, the severest grade of FIGO. Okay, so seriously, it's there in the TOG article. They are indicative of deep AVT invasion and have been linked with increased blood loss and requirement for hysterectomy. Now let's go to 3D ultrasound. 3D ultrasound, there is just one or couple of signs that are very important for the past diagnosis. Okay, 3D ultrasound features. By the way, 3D ultrasound is nothing more of a 2D ultrasound, but taking multiple slices. If I take, this is the 3D ultrasound probe, as you can see. Okay, it's big. You know why it's big? It's big and thick and, you know, globular like this. Why? Do you know the reason of it? Because it contains a motor inside. There is a motor rotating inside. This motor will allow the probe to take multiple, 1 second. Yes. Multiple cuts, one after another, one after another, one after another, until we get something like this. Yes. You know the sticky notes? It's a brand new sticky note. Yeah. So basically the 2D ultrasound will give you just a slice like this one. Slice, one slice. Okay, let me just adjust the light. It's one slice. 2D ultrasound. It has like 2 diameters, this one and that one. 3D ultrasound will get you another one, another one, another one, another one, another one, another one. And they pack them all together like this. Now see, we have a thickness. So instead of just having this diameter and that diameter, no, we have from the multiple slices of the same region, we have now a thickness. In this thickness, we can do cutting and we can get more data. You know, we can get the coronal section, for example, this one. To get the point, this is exactly the same as the 3D CT and 3D MRI, okay? We can also get to put 2 layers together in order to enhance the drawing or the signal. For example, if I wrote just right there, okay, where is another pen? Thing is that this is a line, can you see? This is a line, okay, this one, okay, and this is another line from the another paper. If I put both together like this, okay, they should enhance each other. Now you should see it more clear, right? I know it's not that evident, but this is one of the modality of the ultrasound to enhance the picture, to put 2 slices over each other so we can see it even clear, even better, okay? This is the idea behind this tram line appearance. This is tram line basically. This is the 2D ultrasound, this is the 3D ultrasound. Can you see this is the placenta? And this T-shaped thing, can you see this T-shape? Let me get my laser pointer for you again. Okay, T-shaped, this is the tram line, which is basically another fancy name for the clear zone. It's a clear zone, but it appears in the 3D ultrasound as a tram line, okay? There is a partial obliteration, means loss of some parts of this uterine bladder interface, or full obliteration is a complete obliteration of the uterine bladder interface. See, this is normal, and this is abnormal. It's in picture B. Did you get me? Because now we can see it better, so it doesn't appear as a single line, the utero-bladder interface, uterovesical interface. It does not appear as a single line, it appears as a tram line. There's more details now we can get from this line. Okay, from this 3D enhancement of pictures. So if you remember one thing about the 3D, there should be a tram line, which is the uterovesical interface. It should be clear and like double line, as you can see there. But in placenta, accreta, and invasion, it's interrupted. Okay, I'm sorry, I think I took too much time in this topic, so let's just, rush through the notes. Okay. This is a potential question. might come in your exam. What are the most commonly reported features in both past and normal placenta? The things would give you high false positive rate. The thing you can see in the ultrasound, you can see in placenta accreta spectrum, and also you can see in pus. These, first of all, lacunae. Because why is this? Because they're often confused with lakes. Number two, subplacental hypervascularity. Right? Because I told you before that usually we have too much blood vessels in the placental bed, even during normal pregnancy, right? If you remove the placenta, you see some bleeding coming because the placenta is, the uteroplacental vascularity. And listen, careful attention, please. Irregular bladder wall, not interrupted, not an equal sign. So this is what I emphasized earlier, that you must see the equal sign in order to tell this is interrupted, not irregular bladder. Irregular bladder wall means there's adhesion, just simply. It doesn't mean that this is pus. So these are the three most commonly reported features. Irregular bladder wall, lacunae, subplacental hypervascularity. What are the features that increase the probability of pus or uterine dehiscence? So that now we try to move away from the placenta, normal placenta, and now we're suspecting either pus or uterine dehiscence. If you just read them, it makes a lot of sense. Placental bulge, bulging of the placenta because the uterine dehiscence, there is a very thin scar, so placenta can bulge inside the bladder. Bridging vessels, thin myometrium, less than 1 millimeter thick, loss of retroplacental clear zone. Also, it's not there in the uterine dehiscence. All right? Because there is a very thin myometrium. There is nothing to be a zone between nothing and the placenta, because there is no myometrium in the first place. And it's just serosa or scar tissue. So this is the placental bulge, thin myometrium, bridging vessels, and loss of clear zone. So loss of clear zone, because we've talked about it too much today, is a common feature between uterine dehiscence and pus. Rule of MRI, it's debatable, it's not clear, but you should order it, especially if the patient is obese or you can't see the level of invasion, or there is obese patient or posterior placenta. And this is another intersection point between this TOG article and NICE guideline. So consider MRIs to complement, not routine, complement ultrasound finding when planning ongoing surgical management of accreta spectrum. And you have to discuss it with the women, what to expect during MRI procedure, because some women have agoraphobia, like feeling from closed spaces. And we see, this is why they invented this open MRI and open CT, if you ever heard about it, if you ever heard of it, okay? The MRI can help clarify the degree of invasion, particularly in posterior placenta. And this TOG article also emphasizes the role of MRI in posterior placenta and in obese patients. It doesn't mean that every case with placenta previa accreta, you should order or refer the patient for MRI. No. If you can't see the level of invasion, if the patient refused TVUS, obese, posterior placenta, then you can do the MRI. Okay. So a couple of slides left for in this article, lakes versus lacunae, because they talked about many in a big paragraph like this in this TOG article. These are the lakes. Of course, it's clearly different from the lacunae. They're smooth, they are maybe 1 and 2, and they have this, if I zoomed here, they have this white line contour. They have a white contour. Can you see this white contour? This white contour. This one. This white contour. In the TOG article, they called it echogenic cystic lesion. Why echogenic cystic lesion? They are filled with blood, but the blood inside it is not turbulent. There is no aliasing effect. There is no high velocity blood. There is no back and forth blood coming to and through the probe. It's just simple blood. You can see it. We see it a lot, by the way. It's a sign of placental maturation. And this is why we mention it. It's one of the most features seen between the normal placenta and the pus, lacunae, because it's often mistaken as lakes. Lakes mistaken as lacunae, I mean. So this is a copy and paste from the TOG article. This distinction between physiological lakes and lacunae can be challenging, despite resulting from different physiological processes. Lakes are a common feature of normal placenta. They are homogeneous, hypoechoic lesions found anywhere within the placenta, not just at the placental bladder thing or at the placental bed or something. No, it can be in the front of the placenta, can be found anywhere, can be seen anywhere. It does not appear as moth-eaten. No, maybe up to 5 cm or more in size, especially if marginal, because they have different central lobar, central, and marginal. They have different types. Lakes have peripheral echogenicity sometimes. If they have a called echogenic cystic lesion, just like the one I told you, this one, which gives you a reassuring sign that this is not like this one. See this one in the C, picture C? It's very clear, it has white contour. If you see this, it will reassure you that this is a lake, not a lacunae. Okay? If you see this echogenic cystic lesion associated with intervallar thrombosis and the placenta insufficiency, not due to invasion, this is not a pus thing. خلاص, we almost finished. Yes, C is normal. C is normal. This C structure is normal. This, by the way, this is a mature placenta. Later in gestation, we see white dots, comma-shaped dots inside the placenta due to placental calcification. It's called calcific degeneration of the placenta. That means the placenta is mature, right? Especially, we can see it also when you're examining the placenta by your hands, visual inspection of the placenta itself. Calcific degeneration results from placenta insufficiency, which is normal physiological changes of the placenta that took place by the end of the pregnancy. This is why it starts by thrombosis, white line around this lacunae, then later on deposition of the calcium. Okay, this is what's meant here by the associated with intervillous thrombosis, the intervillous spaces, gut thrombosis, insufficient. This is normal changes to the placenta, placental aging. Sometimes they call it placental aging. Then later on the calcium deposition. So if you see this white contour around the lakes, this is a reassuring sign that this is a lake, not a lacunae. It's called echogenic cystic lesion. It mentioned like 3 or 4 times in this TOG article. Okay, but the lacunae in the past, they're numerous, large, irregular, hypoechoic, no echogenic cystic lesion, and it's usually found in the basal plate, like towards the myometrium, not in the central or marginal. Okay, associated with other things, and also there is no turbulence flow inside the lacunae. Inside the lakes, turbulence flow more than 10 cm per second. Which is called high velocity flow. And now we know how to read the Doppler finding, usually seen inside the lacunae rather than the lakes. We mentioned this. Final 2 slides in this thing, how to differentiate between the uterine dehiscence and the pus. This is the third and most important table today, and the final table today. Khalas, get ready, we're almost done. Myometrial thinning, clear. We can see it in pus and we can see it in uterine dehiscence, right? We mentioned this. Uterine dehiscence, basically, uterine dehiscence means very thin myometrium, right? We can see it also in pus due to invasion. Loss of clear zone, yes, we can see it in pus, and also we can see it in uterine dehiscence. Because uterine dehiscence, again, there is no myometrium for a clear zone to be between 2 tissues. There's no myometrium. Myometrium is less than 1 millimeter. So there's nothing between the placenta and the bladder. Because the clear zone, it's a zone between the placenta and the myometrium. But in uterine dehiscence, there is no myometrium. It's less than 1 millimeter. So that's why we can't see the clear zone. Separation sign likely to be absent. And Also, it can be absent in uterine dehiscence if the myometrium is vanishingly thin. So those three things, the myometrium thinning, loss of clear zone, separation sign, those can be found in both pus and dehiscence. Also the placental bulge. So now four things can be there between pus and uterine dehiscence. It's actually there are 5 or 6. Myometrial thinning, placental bulge, loss of clear zone by 2D ultrasound, and separation sign is absent in both of them. No, uterine dehiscence is something completely different from pus. In uterine dehiscence, there is no invasion of the scar. It's very simple condition, and it managed by placenta will be removed right away with no difficulty in removing the placenta. We just do resection of the lower uterine segment and that's it. Okay. Lakes Alachny. There is Lakes Alachny in both the uterine dehiscence and the scar, but in the Lachny are distinctive feature for the accreta, for the pus. Lakes found in the uterine dehiscence, but you can't see lakes, or I mean Lachny, the tortuous moth-eaten in uterine dehiscence, because it's a sign of accreta. Okay, Lachny blood flow, it's turbulent, more than 10 cm per second, high velocity, while it's slow or no flow seen in color double because they are lakes, not Lachny. Bladder wall interruption, very important, not irregular, not irregularities. Again, irregularities, this is a common feature between normal placenta and pus, but interrupted bladder wall and due to bridging vessels are distinctive feature for accreta, but not for uterine dehiscence, because there is no invasion, no hypervascularity, no hypervascular, subvascular, retrovaginal vascularity in the uterine dehiscence, unlike the pus. So this is why we see bridging vessels and bladder wall interruption. I did this red box because this is one of the most things that you'd use to differentiate between dehiscence and pus. Bladder wall interruption and bridging vessels. Focal exophatic mass, this is what I said, extremely rare, can be seen. By the way, there is a typo here in this TOG article. This should be hyperechoic, not hyperechoic creme. Okay, hyperechoic, this is echogenic cystic lesion, the feature of the lakes. Utrovesical and subplacental vascularity, yes, can be seen in the pus, but not in the uterine dehiscence. Intercervical lakes, I said this is, corresponds with the grade 3, see, the can come as an exam question, grade 3C, the one that might require a high likelihood for hysterectomy with the placenta accreta, but not with the uterine dehiscence. By 3D volume rendering, as I told you now, what's 3D volume rendering now? Again, two things at the same time to enhance the appearance of things. Loss of retroplacental clear zone, tramline disruption. Okay? But this is not seen in the uterine dehiscence. That's it. Almost 2.5 hours. Okay. I had to rush, seriously guys, I had to rush through the last part of this TOG article, otherwise we're not going to finish. So, yeah, TOG article is now, I think it's easy, but yeah, it needs just repetition and question. Thank you so much, and apologies for the interruption. Thank you.